Hello and good morning everyone, and welcome to our fourth Insight presentation for this semester. My name's Jeff, I'm the director here, and it's my pleasure to welcome you all today. Before I continue, I'd like to acknowledge the traditional owners on the land on which we're gathering and learning today, and pay our respects to elders past, present and emerging, and extend that welcome to people in the audience or on webinar land who are joining us today. It's my great pleasure to welcome shortly to the stage Dominique de Andrades. She is a research fellow at the UQ Lives Live Well research group, and a really fascinating topic for us, particularly in the context of what's happening in Queensland at the moment around AOD treatment within corrections and correctional facilities. So please welcome to the stage Dominique.
Thanks, Jeff. Well, I told Leanne when she gave me a job that the thing that I need to work on the most is public speaking, so I'll give it a go today. So, I'm going to be talking today about substance use treatment in prison populations. I'd like to start talking a little bit about the health of prisoners in general and their needs. Their treatment access in prison internationally and what the options are, and then I'll be talking about a review that I've done recently with Leanne on drug and alcohol treatment effectiveness in prison, and the outcomes being recidivism or drug and alcohol use. And I'll be then talking a little bit about what's happening in Queensland and what the implications are of the review that we did with regards to policy and practice. So, health of people in prisons. Well, they often present with really complex health needs and welfare needs. They come into prison with really high rates of mental illness, drug and alcohol dependence, infectious diseases like hepatitis B and C, much of that being related to risky injecting drug practices. They also have high rates of tobacco use, so that's about 4 times higher than what we see in the general population. And they also suffer from high rates of homelessness and unemployment compared to other people in the general population. In the 2015 Health of Australia's Prisoners Survey, it suggested that a lot of people come into prison and they really improve in their mental health and physical health. They have access to medication, they have access to healthcare, they have 3 meals a day. A lot of them get into a habit of exercising every day and find that quite a social event to do on a daily basis. So they actually start to feel really good. There is a small proportion of people that come in, and we know from some work in Australia done by Stuart Kinner that in his work on a Queensland cohort, about 1 in 8 people continue to inject drugs in prison. And obviously in that environment with sharing equipment, they're at very high risk of contracting infectious diseases. What happens when they get released? So what we know is they often leave prison and they return back to their pre-prison lifestyle. So they go back to, a lot of people go back to using risky drugs and alcohol in a risky way. We've got high rates of non-fatal and fatal overdose, particularly in the first 2 weeks out of prison, and to a lesser extent in the first month out of prison. High rates of homelessness, and they're also at a very high rate of reoffending. So about 40% of people reoffend, well, I won't say reoffend, are reincarcerated within 2 years, and a lot of that happens in the first 6 months to a year. So that's a bit of background about prisoners in Australia and their health and their needs. If we look at how people, or part of why people end up in prison from drug use, a lot of it is to do with how the drug policy of that country treats drug use. So whether they treat it as a public health problem or a law enforcement crime problem. So drug policies frames how drugs are used by individuals in society and what happens to them with regards to health and justice. And if we just have a quick look at a couple of different countries and how their drug policies have shaped what's happened with prisoner numbers. In the US, Richard Nixon brought in the war on drugs in 1971. And since then, they've had a six-fold increase in prisoner numbers with very little corresponding decrease in crime or drug use. They have an incarceration rate, incarcerated individuals are 7 times more likely to have a substance use disorder, I should say, than individuals in the general population. And the people that were hardest hit with this drug policy were those that were already living in hardship. If we can compare it now to the Dutch model, in the Netherlands they had a heroin epidemic in the 80s and they started to see very high HIV rates. And their response to that was to develop a model that balanced law enforcement and public health responses. Is probably more on the public health side. Only 10% of convicted offenders go to prison. Most of them receive a community-based order. Drug diversion's used quite a lot. And we've seen there a significant drop in their prison population over the last decade. And they now have the lowest rate of recent injecting drug users and HIV incidents in Europe. And they've also had a decrease in related crime, drug-related crime. And this success is largely due to this dynamic drug policy and having these harm reduction practices in place. This is just a table of about 40 countries around the world that have 4 million or more people as in their population, and it's ranking countries based on their prison rate per 100,000 population. So you can see the US is up the top there. Australia is 119, and that's just looking at harm reduction policies that these countries have in the community. So most countries have needle exchange in the community, most countries have opioid substitution, and a few countries have drug consumption rooms, including Australia. If we look at the prevalence of drug use and people coming into prison, in Australia that's sitting at 70%. 70% of people coming into prison say that they've been using drugs. The last column there is prison harm reduction practices. So what countries actually use these harm reduction practices that they're using in the community in prison, and very few countries are actually using harm reduction practices. Most countries, if they're using anything, will be using opioid substitution. Why does all this matter? Well, the UN Nelson Mandela rules state that the healthcare that's provided in the community for people should also, healthcare that's provided in prison should be at the same standard of healthcare that's provided in the community. And as you can see from the last few slides, a lot of countries are not actually living up to that rule, including Australia. So the rule states that the provision of healthcare for prisoners is a state responsibility. Prisoners should enjoy the same standards of healthcare that are available in the community and should have access to necessary healthcare services free of charge without discrimination on the grounds of their legal status. Healthcare services should be organised in close relationship to the general public health administration and in a way that ensures continuity of treatment and care. So despite these rules, very few people receive drug and alcohol treatment while they're in prison. So in the US, only 11% of prisoners receive drug treatment, and most of that is not evidence-based. And in the 2015 Prisoner Health Survey, 8% of Australian prison dischargees reported accessing an alcohol treatment program while they're in prison, and we know that alcohol dependence is very high in prisoner populations in Australia. It's probably 3 to 4 times, if not 5 times, higher than that rate. So opportunities for prison-based intervention are often missed. So that brings me to the review that we did, which was looking at drug and alcohol treatment and its effectiveness in internationally in reducing drug and alcohol use and recidivism. We were interested in looking at essentially what best practice, what's out there to develop, best practice and what can inform best practice in prisons. So we looked at studies that were published between 2000 and mid-2017. We searched public health, psychology and criminology databases, and then we used some techniques to ascertain any further articles that didn't show up in our search. We included any articles or studies that were whereby the person were classified or self-identified, the participants were classified or self-identified as drug or alcohol users, or they were engaging in risky drug-taking practices. They reported substance use post-intervention. So the outcome that was reported was substance use post-intervention or recidivism post-prison release. And they had to be available in English, and we didn't include any qualitative studies or juveniles. We used the Effective Public Health Practice Project's quality assessment tool. That's a mouthful. So this is a tool that's really great for any public health project. It's quite easy to use. It's got very high validity, construct and content validity, and inter-rater reliability. And studies are essentially rated as being strong, moderate or weak based on a set of criteria, and those criteria are selection bias, study design, confounders, blinding, data collection methods and withdrawals. So we found just over 2,000 papers, and we got down to 49 studies which were reported in 62 articles. So a lot of the studies were, we split them into being psychological studies or pharmacological studies with regards to the intervention type, and we had a couple there that were a combination of psychological and pharmacological intervention. Right now I'm going to talk about the pharmacological ones, and I'll move on to talking about the therapeutic communities, which was also the main psychological intervention type that was highly effective. There were a few CBT and motivational interviewing studies, but they weren't, especially when compared to therapeutic communities, they weren't as effective as therapeutic communities. So I'm going to focus on those today. So these were the studies that had a pharmacological intervention, so methadone maintenance, buprenorphine, and essentially you can see a pattern of almost all of those studies having really great outcomes for substance use. So that may be like post-release, or a couple of them actually followed them in prison, but you would see most of the outcomes post-release. So pharmacological interventions are particularly effective for substance use, not as much for recidivism. Only about 50% of the studies that looked at recidivism as an outcome actually saw great effects. So to talk about a couple of these studies, the Dolan study, if anyone knows Kate Dolan, she's leader in prisoner health in Australia, and particularly harm reduction. She's done a study starting in 2003, and the last follow-up was in 2012, looking at methadone maintenance, where there was 382 participants, males, and a methadone maintenance group was compared to a waitlist control. At the 4-year follow-up, she used administrative data and found that there were 17 people in the cohort that had died, 8 from overdose. None of those were on maintained their methadone after release from prison. And as far as reincarceration went, at the 4-year mark, those that had been on the methadone maintenance and continued to use it when they were released, their reincarceration rates were up to 70% lower than those that were in the control group. At the 9-year mark, for those that continued to use methadone after release, their reincarceration rates were 20% lower than those that were in the waitlist control group. So it has this long-term impact on reincarceration, but also, one of the main outcomes that has been used here in death, and I hate to use that as an outcome because it's quite morbid, but it just shows that it's highly effective with this particular population in saving lives post-release. I guess another one of the studies that I'd like to talk about is the Kinloch study. So it's the second from the bottom, which was a combination study. So individuals were randomised into either, just males, 211, randomised into either counselling plus methadone, and then a third group of counselling plus methadone in prison and post-release. And as you can imagine, the effects were staggered between those 3 groups. So the group that did the best at 12-month follow-up were the group that had counselling, methadone in prison, and then on release as well. We saw significant reductions in heroin and cocaine in that study. Heroin and cocaine use post-release at 12 months. All right, so I've talked a little bit there about the opioid substitution treatment, showing those pharmacological interventions. And I'm going to talk now a bit about the therapeutic communities. So as I said, they were quite effective in reducing recidivism. So they had the opposite effect to OST, quite effective in reducing recidivism, not as much with substance use. And I think what was really evident in the OST studies, and any study basically that had aftercare, that group always did significantly better than groups that just had OST in prison or were in a control group. There was, especially in the pharmacological studies, there's a lot of studies there that are US based, and although there are half of them that are RCTs, there's only 6 strong studies across all of our studies. Part of the issue there being that a lot of studies have very high attrition rates, so people leave prison while they're in the middle of the study, and there's also selection bias, so often to stop that from happening, they'll only let people in the study who have a long sentence or are about to leave at a certain time, and that eliminates a group in prison from participating. Sorry, just a little bit about OST with Aftercare. As I mentioned, significant treatment effect was seen when there's aftercare provided, and significantly lower reincarceration risk was found when you compared OST only in prison to no treatment. So even just using OST in prison compared to no treatment still has an effect. It's not as good as with aftercare. There's also a study there that looked at extended release naltrexone, and they also found that lower rates of reincarceration were found with the participants that received that compared to controls. And obviously the two studies that used the combination of OST with psychological treatment had really great outcomes, as I described one of them earlier. So moving on to therapeutic communities, these in the prison context are distinct units that are separated from other prisoners on the prison grounds. Our research suggests that they're moderately effective, but they're one of the more effective types of treatment when you compare them to other types of treatment such as CBT or motivational interviewing. And as I said, there's a large number of RCTs, but they often suffered from limitations that we commonly see in prison research. So we looked at 7 studies examining substance use outcomes. Only 2 of the RCTs found that therapeutic communities were superior when compared to CBT. And 4 out of the 7 studies found therapeutic communities resulted in improvements at the 3 to 12 month follow-ups. However, all trials that followed therapeutic community participants for longer terms than that, so 2 to 5 years, found that it had no effect. So what that suggests is that therapeutic communities have a great effect on individuals for the first year when they come out, but if there's no aftercare and maintenance, then that effect wears off after about a year. And the aftercare groups, those studies that did have aftercare groups, had significantly better substance use outcomes. One example I've given there is the Amity prison evaluation. So they did 3 follow-ups, and at the 3-year mark they were still finding a significant difference between people that had therapeutic community treatment versus people that had no treatment. So 27% of the individuals that got therapeutic community plus aftercare recidivated versus 75% of people that didn't get the treatment at the 3-year mark. And they used hair and nail drug tests. So that's the 12-month follow-up figures there. So you can see that the group that got therapeutic communities plus aftercare did significantly better than those that just got therapeutic community or the control group at the 12 months. To look at recidivism outcomes, 11 studies reported recidivism outcomes. 10 of the 11 reported significantly lower rates of recidivism, so that's rearrest or reincarceration at follow-up. So therapeutic communities, as I mentioned earlier, have better outcomes with regards to recidivism than substance use, we found. So 2 of these successful studies with long-term follow-up found that those in the treatment condition that engaged in aftercare post-release experienced significantly lower rates of reincarceration and rearrest compared to those in the control and treatment groups. So just to put all this in context of what's happening now and how all this can impact on current policy and practice, what we know is that we have this brief period of time for some people and an extended period of time for others when they come into prison, where we can address some of their chronic health needs and improve outcomes around drug and alcohol use and mental health. And they're a very vulnerable population that do need this assistance and some help, particularly with these issues, but also there's a lot of other issues going on that we know, such as housing, that can make a big difference for someone when they come out and create some stability. There's a critical need for targeted evidence-based treatment for opioid users that withstands the strain of the community re-entry. So we know that that's such a critical time for them, a time period when they can go back to drug use and find themselves in serious situations, and some really solid support around that time and help engaging with health services can be quite critical. And we need a cohesive approach between prison systems and public health officials, and a commitment to providing the same level of care that we provide in the community in the prison setting. And we also need investment in aftercare programs. So much of the evidence that we found suggests that every time you add aftercare into the mix, you get much better results for people and long-term results, particularly with their substance use. And we know that it can save lives in that critical time. I don't doubt as well that it would also prevent some people from potentially engaging in risky drug-taking practices in prison as well if they had access to OST. And my last point there is that the investment in aftercare programs can extend the benefits of treatment programs we're already seeing in the community. Just a little bit about OST in Queensland prisons. So the current situation. Obviously, I've just presented a lot of information about how effective OST can be, and also the fact that a lot of countries aren't actually providing this in prison to prisoners, even though we've got a lot of international evidence suggesting that it's effective. And in Australia, Queensland is the only jurisdiction that up until this point hasn't had OST in male prisons. So we've had it in women's prison, but not in male prisons in Queensland. And there was a recent Queensland parole system review that suggested that, made a recommendation that OST becomes part of the treatment available to Queensland prisoners. And that's been taken on board. So we'll soon be seeing the rollout of OST across Queensland, which is going to include maintenance and initiation. And I think it's a bit of a watch this space scenario, but a good one. Yes, that's all.
Thank you, Dominique. Any questions from the audience here? Thank you.
Hi, thanks for the great presentation. What classifies aftercare that would get included into the research, and also what classifies therapeutic community? I'm not familiar with that.
So aftercare is when they continue on in it with a maintenance program when they come out, like a methadone maintenance program, for example. When they come out of prison, they continue to take it. They might engage with their GP or or a local health service, and they could just continue on with their program that they're currently taking in prison. With therapeutic communities, they are they're essentially in a completely separate unit from the rest of the prison, and therapeutic community, the actual individuals in that group are the therapy. So supporting each other, having group sessions. Peer support, yeah. There isn't too much intervention. There's group sessions and really supporting each other through getting through their, I would say when they first come in, withdrawal, but also talking about their addiction. But it's very much about, yes, peer support with little intervention. It's highly effective.
Dominic, do we have TC models here in Queensland within our prisons that you're aware of?
I think a few years ago I knew of one drug unit.
Yeah.
I'm not sure if that was run as a therapeutic community. They may still have drug units, I'm not quite sure. Yeah. I guess, sorry, to answer your question further, it originated from the 12-step AA model. And so there's a few different models. There's like a 12-step Minnesota model. It originates from AA.
We're also aware that Queensland Corrective Services are taking or adopting a more therapeutic approach to treatment provided within prison, but also within probation and parole. And are partnering with alcohol drug services around that, which is pleasing and encouraging.
Thanks, Dominique. I'm just wondering, did any of the studies look at the role of mutual aid groups, so attending things like Alcoholics or Narcotics Anonymous after prison? Because we just know internationally that clients that leave residential treatment that go into those groups tend to have the best outcomes in the short and the long term.
Not that I recall. I know that there's definitely, a number of people came out of therapeutic communities and went into a therapeutic community setting in the community, but I'm not sure if it was exactly what you're describing. And a lot of the studies didn't actually have good descriptions of what they were providing, so
I think it just points out they need to define what they mean by aftercare and continuing care and what that means.
yes.
Yes, because aftercare in the treatment setting is more around psychological services as much, whereas this seems to be more around continuation of your maintenance of your OST. So just for people in the audience to be aware of that distinction in the research in terms of aftercare. Any other questions?
Sorry, I'm just wondering, why was it provided in female prisons but not male prisons? Do you know why OST? Sorry.
I'm not sure of that either, Kath.
Does anyone know in the audience? Yeah, Jim?
The male prisons were privatised, so it reduced the profit motive. Was it needed extra supervision for corrective staff to supervise?
It was also because of pregnancy and things like that as well.
It was also for pregnancy and maintaining women that were coming through that were pregnant or may have been pregnant. So that one.
Yeah.
Interesting. 2 seconds. Any other questions or comments? Do we have any questions online, Ben? We do. Is there any idea around, is it being offered in youth detention centres, do we know? Maybe you don't know the answer to that. Or?
I'm pretty certain it's not.
Yes.
But I can't.
Internationally, is it ever offered in youth detention centres that you're aware of?
I've only ever looked at adult prisons. With that research in the table that I showed, it's all about adult prisons, so I'm not sure on that.
Sure. I think that might be it. Let's join me in a round of applause for Dominic. Thank you.